Hi, I'm Bridget Harley, clinical audiologist at the Hearing Clinic. We have Mr. Stephen James Quinn, consultant ENT surgeon at the Eastern North Hearts NHS Trust. And today we're going to be doing a Q&A on sudden sensorineural hearing loss. Thank you, James, for joining us today.
Thank you, Bridget.
What is sudden sensorineural hearing loss and why is it such an emergency?
Sudden sensorineural hearing loss, defined as hearing loss which comes on within a 72-hour period.
Okay, really quick.
Yeah. The evidence is tending to point towards the fact that if we treat it early with relatively high dose steroids, that we do affect the outcome positively, and that window for treatment is quite small.
Okay.
Ideally within a week. Definitely within a couple of weeks, and maximum 6 weeks. Beyond 6 weeks, I think everybody feels that there's no point treating the loss, and therefore the chance to improve the outcome is lost. NICE has some criteria on referral for sudden sensorineural hearing loss. It should be referred as an ENT emergency to the on-call ENT team. Locally for Eastern North Hearts Trust, the referral should be through the emergency on-call team, and probably what they will do is that they will book the patient into an ENT acute clinic. Now we have those running 5 days a week.
What can cause a sudden sensorineural hearing loss?
The vast majority, probably about 95% of them, will what we call idiopathic.
Yeah.
Now, idiopathic sudden sensorineural hearing loss may be due to one predominant thing, or it may be due to several. We don't know. It does tend to get more common as you become older, which means that there may be a degenerative or a vascular component to it, and I think vascular is probably quite a high possibility or probability as a cause, microvascular within the cochlea, and the other possibility is that there may be a viral element to it, or a viral infection could possibly cause that. So the key thing really is for the attending clinician, primary care clinician, to be able to define whether this is an inner ear or a conductive loss. And there are obviously some key factors that will help. Firstly, in terms of the history. Okay, yeah. Sudden sensorineural loss is quite a typical history. It usually goes along the lines of, I woke up one morning and I lost my hearing in one ear. I mean, that is a typical history of a sudden sensorineural hearing loss. Sudden sensorineural hearing loss has no trigger, that's obvious, but it tends to occur at night time or in the morning. That seems to be the most likely time. It may be associated with other symptoms such as vertigo, and rarely with neurological symptoms, including facial paralysis or ataxia, etc. And that obviously would raise the possibility that there may be a neurological cause, such as a small stroke causing it.
In primary care, what steps would you recommend a GP take in order to come to a differential diagnosis?
So obviously we need to know the timing of the hearing loss, when it occurred, over what sort of period of time. Was it instantaneous, a couple of days? The next step obviously is to examine the ears. Yes. What we'll be looking for will be signs that are really, really clear. So most people have some wax in their ears. So having wax in your ear doesn't mean that you haven't got an inner ear hearing loss. If the wax looks like it's completely obstructive, or if there's signs of infection or something else going on, then obviously that's an indication that there may be a conductive loss. And then we come on to middle ear effusions, and the evidence that I would have around with me if I was in primary care is a tuning fork. A tuning fork. Yeah. So the tuning fork is an extremely reliable test for conductive hearing loss. Yeah. And particularly the Weber test, if you put the tuning fork on the forehead, it will go to an ear with a conductive hearing loss. So if an ear has a conductive hearing loss in it, the tuning fork will go to that ear.
So what would be a good suggested protocol for steroid prescription?
Right, so if you have a patient that you suspect has sudden sensorineural hearing loss, and you're seeing them within 2 weeks, well, maybe 6 weeks of the event, then I would suggest that you phone the on-call ENT team and discuss it with them. They may suggest that you give the patients steroid if the history is compelling. But if it's a Friday afternoon and we can't see them till the following Tuesday, then and it's been 5 days or something since it came on, then it may be better to give the steroids without the hearing test. The usual dose of steroid is 1 milligram per kilogram, up to a maximum of 60 milligrams. I think no one's quite clear how long it should be. I actually supply it for 10 days because then you don't have to tail it off and you can just stop it. Other people like to give it for a bit longer and tail it off after between 10 and 14 days. If there are concerns about whether the patient can tolerate what is a moderate dose of steroids, then you can have a discussion with them and give them a lower dose maybe.
What will affect the prognosis for a given patient, do you think?
So the two things that really, well, the three things actually would be age, the severity of the hearing loss, and cardiovascular status, which brings back to what I originally said, was I think quite a lot of these probably are vascular.
What sort of things do we need to consider for follow-up with these patients? So what things may come back?
So a small proportion of sudden sensorineural hearing loss is due to vestibular schwannoma, about 1 in 100.
Okay.
So it's a pretty small number. But routinely we would offer an MRI scan.
And then I guess management of hearing loss.
Yep, and then obviously the hearing will usually settles at about 3 months. So what we would normally do, we'd see the patient in the acute phase, we would treat them with oral steroids, we then follow them up, maybe consider a rescue with intratympanic steroid after, say, 4 weeks or something if they hadn't improved, and then we'll probably see them again at 3 months for a final check. At that stage, the hearing is going to be quite stable, and so at that stage you have a baseline and you can then discuss, counsel them about hearing aid use.
So it's about the speed of onset is typically unilateral. The case history has to explore these things we've discussed. Otoscopy plus tuning fork tests, very valuable.
Yes.
Give a call to the on-call ENT and try and get the patient seen in the next day clinic if possible.
Yep.
And then take advice on steroid prescription from the ENT.
Yeah, if rapid ENT input isn't available and the evidence is strong, then I think that, and the patient has no contraindications to oral steroids, then I would suggest starting the oral steroids.
Yeah. Great. Well, thank you for your time today.
Okay.